Good afternoon, everyone. My name is Dr. Orla Hilton, and I am an academic foundation doctor working with the Liverpool Brain Infections Group. It's a real pleasure to have been invited to organise today's Global Brain Health Clinical Exchange platform on paediatric brain infections. And I hope it will be a really good session today. We have some very exciting speakers, so I'll begin by introducing our chair, who will open the session, and he will subsequently introduce the speakers. After the talks, we'll have a panel discussion, and please stay till the end, which is where I will present some of the upcoming research, learning, and funding opportunities. So it's really worth staying on until the end of the talk today. Now I would like to introduce the chair, Dr. Stephen Ray. Stephen is an academic clinical lecturer based at the University of Oxford. His research interest lies in improving diagnostic and prognostic markers and better understanding the pathobiology driving poor outcomes in central nervous system infections in African children. His Wellcome Trust Clinical PhD Fellowship was primarily based in Malawi, where he collaborated with the Blantyre Malaria Project and the Malawi Liverpool Wellcome Trust. During this period, he also was a PI on a national study in the UK investigating the neurological manifestations of COVID-19 in children. So with that, I'm delighted to introduce Stephen, who will kick off today's session. So thank you very much.
Background is CNS infections, particularly in low middle income settings. So it's wonderful to have the opportunity to listen to two, world experts on this area. So just to give you a kind of overview of what's going to happen this afternoon, there's going to be a 10-minute talk from Professor Ronald van Tuin, who's a world-leading paediatric neurologist. And then after that talk, there's going to be a further talk by Associate Professor Dr. Tinsay Alamai, and he's calling in from Ethiopia. So just to start with, just in terms of practicalities, it's really important in these sessions. We've got a whole range of people from all over the world. I'd really appreciate it if people do engage in the Q&A option at the bottom bar. If you just click on that and you can enter relevant questions. As I say, the structure is going to be, first of all, first 10 minutes from Professor Ronald, and then after that, immediately we'll go into a pre-recorded talk by Associate Professor Tinsay, and then after that there'll be a big broad discussion about both topics and other potential areas of interest about CNS infections in low middle income settings, and that'll last about 25 minutes, and then at the end of the session we'll wrap up with some kind of final thoughts and ideas. So I'm going to introduce Professor Ronald van Tuin, who really needs absolutely no introduction. He's a professor of paediatrics and child health in the Department of Paediatrics and Child Health, and he works in neurology clinically. He's at Stellenbosch University. He's got a broad range of expertise, and particularly one of his key interests is TB meningitis, and he's going to talk to us about that just now. But he also has other research and clinical interests in neurometabolic diseases, neonatal neurology, and epilepsy. His main science has been childhood TB, and he has got genuinely some of the most in-depth research data and interests and expertise in this topic, which is still a huge burden and a real troublesome disease to manage. And for people like myself who work in a UK setting, generally, it's really exciting to get those kind of unique experiences from someone who sees such a huge thoroughfare of disease. Beyond his clinical experience, he's also an established member of the TB Research Consortium, and he's given guidance on TB management to the WHO. Particularly, he contributed to the expert consultation on a shorter regime for paediatric TBM, which is now, as we know, known as the Cape Town shorter regime for drugs susceptible TBM in children. So with no further holding back, I want to hand over to Ronald to take us through his expert work. Thank you very much, Ronald.
Thank you, Stephen. Let me just share my talk. Let's have a look here. There we go. Share. All right. Can you all see my talk?
Yeah, we can see it.
Okay. Well, thank you for the invite, everyone. And as Stephen has alluded to, this is the hospital where I work. It's in front of the picture, and it's in Cape Town. You can see Table Mountain in the background, and you can see the communities that we serve. And unfortunately, there's a very high prevalence of TB meningitis in our setting. As you can see here, South Africa is one of the top 8 countries in the world with the highest TB burdens. And if you look at the graph, China, India have huge TB problems, which is the two most populous nations in the world. What is the prevalence of pediatric TB meningitis? And the honest answer is we're not sure. There's no hard clinical data. It obviously depends on whether you're working in an area of low prevalence, high prevalence, what is the HIV prevalence, and whether you're looking at hospitals or the community as general. In where I work, which is a high TB burden setting, the prevalence is approximately 10% of all TB cases. And if you extrapolate that to WHO figures of new TB cases every year, which is about 10 million, of which 1 million is children, then we're probably looking at 100,000 children developing TBM every year. And that is significant, especially if one considers that there's a 20% mortality associated with childhood TBM in some settings. You may be aware of the Millennium Developmental Goals for TB, and up to 2015, the aim was to stop the increase in incidence and to halve the mortality. And in most countries, that has been achieved. The other aim, I think, is probably a bit more optimistic, and that is to eliminate TB by 2050. And as you can see from the top of the graph, the numbers, unfortunately, the deaths are increasing, most likely due to the disruption caused by the pandemic, the COVID pandemic. Now, these are the challenges that we face in TB meningitis. So I'm not going to go through them all, but you can see it pertains to pathogenesis, the history, epidemiology, there are diagnostic uncertainties. We're not sure what the optimal regimen is, and there's also health system failures. And all of these have an impact on how we manage TB in our society and TBM. I'm going to start with a clinical case, which is something that I'm confronted with on a weekly basis. So we have a young infant, a 2-year-old boy, HIV uninfected, presents with 4 days of fever, lethargy, irritability, and vomiting without preceding nausea. Clinical examination by the GP was unremarkable. There was no meningism. He thought this was probably an intercurrent infection. He couldn't find a focus of infection, started amoxicillin. Unfortunately, the lethargy worsened over the next 7 days. The vomiting persisted. And when TM arrived at the hospital, he was slightly suppressed. He now had meningism, and there was decreased movement of the right upper and lower limbs. So just some important clues with regard to this specific history. It's always important to inquire whether there's a household TB contact, the BCG and HIV status, as well as whether there's a history of weight faltering. The onset of TB is often insidious, so there are often missed opportunities and chances for earlier intervention. Also important is that the symptoms are often non-specific, which often leads to late diagnosis with severe consequences. Neck stiffness is often absent in young children with meningitis, so you can't rely on that. And then very important, vomiting without preceding nausea should alert the clinician to the possibility of raised intracranial pressure. It's not gastroenteritis. So these are the investigations we would do in a low resource setting, and they should be available, I think, in most settings. I think it's important to do a chest X-ray of both the child as well as the caregiver. You don't want a caregiver with cavitating pulmonary TB in your ward because you're going to put the other staff at risk. And when you ask for the chest X-ray, ask for AP and lateral, because especially on the lateral, you may be able to see lymphadenopathy. And we talk about the so-called donut sign, where there's hilar lymph nodes, which fills the whole hilum. Then I think we look at the serum sodium, which is often low in patients with tuberculosis meningitis. The CT scan was done on this patient, and as you can see, the patient has got hydrocephalus. All the ventricles are dilated, the third as well as the fourth. We look for enhancement at the bottom of the brain, it's called basal meningeal enhancement. And then obviously we look for infarcts, and as you can see, there's a hyperdensity in the left frontal lobe, suggesting an infarct. Obviously, then you would proceed, if safe, to do a lumbar puncture. And you can see this child has got the typical features that we expect from tuberculosis, meningitis. There's often not many cells. If you have thousands of cells, it's more likely pyogenic meningitis. And in this patient, you can see the expert, both in the CSF and in gastric washings, was negative. So one important question to answer is, does the negative gene expert rule out TB meningitis? And in this, the answer is no. It's not a rule-out test. We have very good specificity. So if the gene expert or ultra expert is positive, you have TBM. But at best, we have a sensitivity in the high 60s. So you cannot confidently rule out TB. Also important, if you want to increase your diagnostic yield, to provide the lab with adequate amount of CSF, preferably 5 to 6 mL. How do we treat the hyponatremia? We give hypertonic saline. We do not fluid restrict. We know that tuberculosis meningitis is a prothrombotic state, and if you are going to fluid restrict, you may precipitate cerebral venous thrombosis, and you may also affect cerebral perfusion by doing that. Next question is, on the CT scan, this patient has hydrocephalus. How do we treat that? And the answer basically is, it depends on where the CSF block is. It could either be communicating hydrocephalus, which we find in 80% of cases, or it could be non-communicating in about 20% of cases. CT scan is not accurate, cannot tell you where the block is. It's not sensitive enough. And what we do in Cape Town for the last 30 years, we do a very old procedure, which is called an air-encephalogram, where we basically inject an air doing a lumbar puncture, about 5 to 10 cc's of air. And then we do a lateral X-ray. And this is an example. You can see there, the air bubble is right at the top of the brain in the lateral ventricle, and that suggests that you're dealing with a communicating hydrocephalus. There's no blockage in the ventricular pathway. Doesn't help to shunt this child. Doesn't serve any purpose. It's illogical. So this patient would respond to medical therapy, and we give Diamox and Lasix. What the Diamox does is it inhibits an enzyme called carbon anhydrase, which is responsible for CSF production. So this patient has an absorption problem, not a blockage. This is another example of air-encephalogram. You can see the air bubble is right at the base of the brain in the basal cisterns. And this suggests this is a non-communicating hydrocephalus. And this is a patient you are going to refer to the neurosurgeon for a VP shunt or third ventriculostomy. Other question which comes to mind is, what is the most optimal TBM regimen that you would propose? And you can see we've got the Cape Town regimen, which is for 6 months. It's higher dosages. It includes ethionamide compared to the WHO regimen, which is over 12 months, and the agent they use is ethambutol. What you require when you treat TB meningitis, obviously you want to have good CSF penetration, and we know INH and PZA, as well as ethionamide, penetrate very well. Rifampicin is not good, but if you give higher dosages, you get higher CSF concentrations. From the second-line agents, you can see levoflox and taurursodone are also very good, and there's some of the studies are including these agents now. We participated in the study where they compared the Cape Town regimen to the WHO regimen, and basically the conclusion was that they're equally efficacious, so both of them can be used. This is a trial which has recently been completed called the TBM KIDS trial. And what they basically did here is they increased the dose of rifampicin to 30 milligrams per kilogram per day compared to the normal 50 milligram per kilogram per day. And one of the limbs also used levoflox. And what the study basically found is that the outcome was improved. There was a slightly higher tendency towards adverse effects with the high rifampicin dose, but the outcome was better. So now I think most of the guidelines are advocating using a higher dose of rifampicin. Just to end this clinical vignette, so after 3 months of of treatment, TM's mother is now concerned about her son's vision. On eye examination, there's poor fixation and following. He has dilated, poorly reactive pupils. And on vidoscopy, we have pallor of the optic discs. And the question now is, what is the most likely complication? Now, TM is on treatment for hydrocephalus, so it's not intracranial pressure. He's on the Cape Town regimen, so it's not ethambutol. And on imaging, this is what it shows. He's developed an unusual complication, but a visual threatening complication, which is called tuberculosis optochiasmic arachnoiditis. And you can see here there's enhancement of the optic nerves, and you can see also, as well as the chiasma, and there's also a tuberculosis that has evolved on treatment, and we call this paradoxical iris. So the question I have for the poll is, what adjunctive therapy would you offer? I must just add that he's on 3 weeks of treatment, so he's still on his corticosteroids. So the options are, as you can see, should you refer to the neurosurgeon for decompression of the optic chiasm? Should you increase the corticosteroid cover by giving IV methylprednisolone? Should you consider intrathecal hyaluronidase? Should you consider anti-tumor necrosis factor antibodies, infliximab or thalidomide, which is also an inhibitor of tumor necrosis factor alpha, or would you consider using other immunosuppressant agents? I think these are just a summary of the studies where people have looked at host-directed therapies. And you can see aspirin has been looked at because aspirin has anti-ischemic, anti-inflammatory, as well as anti-thrombotic effects. So it should actually work, especially for reducing the risk of infarction. But at the moment, there's still uncertainty as to whether it's efficacious or not. And the evidence is not strong enough for us to include this as routine standard treatment. Corticosteroids has been shown to be beneficial as it reduces mortality, but unfortunately it does not reduce morbidity. And then there's been studies using thalidomide, which I'll come to now. Right, I'm just going to highlight there's another study that is ongoing and we're still waiting for the results. It's called the SURE study. And as you can see, what this study is also comparing the short to the longer treatment regimen. But what the study is also doing is it is looking whether aspirin has a beneficial effect. So hopefully when this study has been concluded, we'll have more information as to whether we should include aspirin as part of our treatment regimen. I just want to end off by highlighting some of our work that we've been doing by using thalidomide. We've probably have experience of more than 50 consecutive patients. We've published our results. Colleagues of ours from Australia, they're also using infliximab, which also targets tumor necrosis factor alpha. And as you can see, this is one of our patients who also had threatening vision. You can see there's thick encasement of the chiasm and the optic nerves. After thalidomide, you can see it's much less. And this is the child, and you can see it's looking at the camera. Full recovery of vision. And I must say that since we've been using thalidomide, we have had not a single case of blindness in any of our tuberculosis meningitis patients. We also use thalidomide when you're dealing with tuberculosis abscesses or mass lesions. And what happens is once you start thalidomide treatment, you should use serial MR imaging if it's available. And what happens to this abscess is it becomes darker over time, and then basically it calcifies and becomes a rubbery nodule like a gummatus. And often you only require treatment for a short period of time, often 3 months, probably sometimes less. But as you can see, it takes a long time for these mass lesions to disappear. But they are there. The patient itself is then asymptomatic. It also works for when you've got spinal cord lesions. This is a patient who had HIV infection, was paraplegic, was virally suppressed on HIV treatment, was on drug-susceptible TB regimen, was cushingoid from the high corticosteroid dosages that was given to this patient. And as last resort, we used thalidomide, and as you can see, it had a positive effect. These tuberculosis mass lesions disappeared on treatment. Right, just to conclude my talk, the best way to improve outcome in TBM remains early diagnosis in treatment. It is our opinion that many of the sequelae from TBM is because of a dysregulated host immune response. So it's critical that we find and identify effective host-directed therapies, because that will improve survival and outcome. After years of neglect, substantial research into childhood TBM is underway. But despite these advances, TBM remains a condition that is devastating, and much remains unknown in the field of TBM therapy. Thank you.
Great. Thank you very much, Ronald, for a whistle-stop tour of a hugely complicated topic and issue that is ongoing. There's a whole raft of questions I think I have and other people have. I think we're going to go straight next on to Associate Professor Tinsay Alamanya's talk, first of all, which has been pre-recorded, and then after that we'll have questions for both talks. So just before we give the pre-recorded talk starting, just to let you know, Tinsay is on the call and he's going to be answering questions, but it's pre-recorded the talk given there's some connectivity problems. Now, Tinsay is also a very vastly experienced person in CNS infections. He's a paediatric infectious diseases specialist in Addis Ababa, Ethiopia, and he actually serves as a vice president of the American Society of Paediatric Infectious Diseases, and he's a recognized emerging leader by the International Society of Infectious Diseases. So a really huge, impressive CV. His research interests are predominantly CNS infections, but also he has an interest in antimicrobial stewardship and congenital infections. So we look forward to seeing his talk now.
Good afternoon. My name is Tinsay Alamanya. I am a pediatric infectious disease specialist in Ethiopia, and it's a pleasure to join you this afternoon to be discussing shunt infections in children. Within the allowed time frame, I'll be sharing summaries of evaluation and management recommendations for these syndromes. Shunt infections are CSF infections in patients with devices used for CSF drainage. This can be ventriculoperitoneal, ventriculoatrial, ventriculopleural. And the mean incidence of shunt infections, depending on where you work, ranges from 5 to 45%. In a large Ethiopian cohort, it was shown that 1 in 4 children with a shunt placed for drainage developed shunt infections within the first 1 month after placement. And that's exactly the commonest time frame where shunt infections occur, the first 30 days, but they can occur up to a year later. So the first poll question that I'm posing to the audience is, which of the following groups of microbes are the commonest cause of shunt infections? Gram-positive cocci, gram-positive Rhodes, gram-negative bacilli, or anaerobes? So you can type in your answers and I'll give you a few seconds to do that. The commonest group of microbes causing shunt infections are gram-positive cocci, of which coagulase-negative staph infections predominate. Gram-negative bacilli infections account for 10% of infections, and in immune-compromised children, you also have to think of candidal infections as well. If you are dealing with infections of internal shunts, then biofilm-producing organisms like coagulase-negative Staph aureus are the predominant etiology, whereas in infections involving exteriorized shunts, then there is a predominance of Staph aureus and gram-negative bacilli. Risk factors for children to develop shunt infections include a prolonged duration of neurosurgery. If the shunt insertion was for hydrocephalus involving open head trauma, severe intraventricular hemorrhage, especially in preterm newborns, the presence of a CSF fistula, especially ventriculoatrial shunts, and the presence of bacteremia in children are all risk factors for shunt infections. The clinical presentation can be grouped into three. There are general signs such as fever, vomiting. There are local signs along the tract of the shunt, redness, worms, swelling, and pain. And also neurologic signs such as headaches, seizures, focal signs, as well as meningeal signs. Shunt infections are a challenging diagnosis, mainly because there are minimal or absent changes in the CSF, especially if you are dealing with low virulence organisms like coagulase negative staph and propionobacteria. The chances of gating pleocytosis, elevations in protein, and low glucose are higher if shunt infections are caused by gram-negative bacilli and Staph aureus, and also, as is clear in many other infections as well, in children who are pre-treated with antibiotics or who have shunt infections due to slow growing organisms like Propionobacterium acnes, as well as coagulase negative staph, initial gram-staining cultures may be negative. Blood cultures are more likely to be positive in ventriculoatrial shunt infections, and the preferred neuroimaging is an MRI. So the cornerstone of management are antibiotics, antimicrobials, and also a revision of the shunt. Antimicrobials can be administered intravenously or intraventricularly. The general duration of antibiotics is for 7 to 14 days, but that depends on the isolated etiology and also the time till sterilization of the CSF. If you have repeated positive cultures, treatment may continue till 10 to 14 days after negative cultures. A reasonable starting point empiric regimen consists of vancomycin with an advanced generation cephalosporin or a carbapenem. The second poll question that I am posing is, when do you suggest the introduction of intraventricular antibiotics for shunt infections caused by gram-negative bacilli, for persistently positive CSF cultures, for shunt infections in preterm newborns, or for post-traumatic shunt infections? Again, I invite you to type in your answers and give you a few seconds for that. So intraventricular antimicrobials are indicated when there is no response to IV antimicrobials and when there is persistently positive CSF cultures. There are dosage formulations for intraventricular administration of aminoglycosides, colistin, polymyxin B, vancomycin, daptomycin, etc. And as I've already mentioned, the other cornerstone of management is removal and replacement of the shunts upon completion of the antibiotics. Complications of shunt infection include prolonged hospitalization, shunt failure, septic shock, neurologic disability, and vegetative states, as well as death. And there are certain gaps in knowledge. So even though there are nearly 14 million people requiring neurosurgical intervention for hydrocephalus around the world each year, there is a paucity of data from low and middle income countries. There is a need for uniformity in diagnostic criteria as well as definitions, and we need better CSF molecular diagnostics. Thank you very much. I will hand over the floor to the moderators so that they can moderate the question and answer session. Thank you.
Great, that was fantastic to say. Thanks very much. Now, as I've just said before, it'd be really helpful if people, having had the time to digest the talks, now just start thinking about putting the questions into the question and answer section at the bottom of the Zoom app. That'd be really helpful to get going. while we're waiting, if you don't mind, Ronald, I'd quite like to ask a couple of questions to start. So, as you said, with the kind of theory about, clearly there's a host immune dysregulation in TBM, and that's one of the central pieces of why we have this awful, huge mortality and morbidity. And I feel like I'd really like your opinion about, the value of trials in some of these immunomodulatory therapies. I know that you and others have shown very robust data about thalidomide from observational data, in very specific situations, but it's still definitely not, in my practice, we don't do such modulatory therapies, despite there being reasonable, observational data. So I guess there's two parts to that question. One is, do you feel that the evidence is sufficient and that's adequate for your practice, and also, do you think that trials are on the horizon? Are there immunomodulatory therapeutic trials would help perhaps us that are less experienced to have more confidence in applying them?
Right. I think we are waiting for the aspirin trial in the SURE study. That may guide us as to whether it's beneficial or not. I think one of the things we are targeting is infarcts. And we know that about a quarter of patients, 25%, develop infarcts on treatment. And we know that the best predictor of a poor outcome is infarcts, and that's something you want to prevent. So corticosteroids is disappointing, as I've said, because it doesn't reduce morbidity, and that's also what we want. We don't only want to save the child, but we want a good outcome. Thalidomide, we've been using it for the last 20 years for very rare complications. The tuberculosis abscess in the middle of the brain that is inoperable, you can't get to it. We've been using it for the optic asthmatic arthritis. And in our experience, you cannot do randomized controlled trials anymore. You cannot do a comparison with placebo. If I tell you we've been using it for 20 consecutive patients, and in all cases we have salvaged vision, then my ethical committee would not allow any other limb, whether it's corticosteroids, placebo, whatever. So that is problematic, and that's the best that we can offer is to publish our results in consecutive patients. There are currently in India, there's a study where they've also used thalidomide at onset, low dose, not high dose, low dose, to see if it makes a difference in outcome. So that is a trial that we are awaiting, and I'm sure there will be trials in future. We don't understand enough with regard to which cytokines are involved, which ones you should target. We believe it's tumor necrosis factor alpha. We believe it's vascular endothelial growth factor. That's important, especially with the mass lesions, because around these mass lesions, there's enhancement that continues for months, and that's because of neovascularization. And we also believe it's gamma interferon that's responsible. But I think we need to know more as to which cytokines drive this pro-inflammatory response. The risk of thalidomide, it's very much dose dependent. It's like a cytokine with a split personality, the tumor necrosis factor alpha. If you don't have enough of it, you may end up with worsening of disease and reactivation of latent TB. So it both has pro-inflammatory and anti-inflammatory properties. So if you look at the randomized controlled trials that we did, it didn't make much difference, but the dose that we had been using is 5 times higher than the dose that we are currently advocating, which is 5 milligrams per kilogram per day. And we find that this low dose is safe. We haven't run into any side effects. And we believe that it is the way to treat these unusual complications in patients. And we have a very good outcome over the last 10 years in these patients. Colleagues of mine have been using infliximab because they can't get hold of thalidomide because it's been banned and it's difficult, it's become very expensive. And they are reporting similar results using infliximab, which is a tumor necrosis factor alpha antibody.
Okay, that's really, really informative. I guess I've been in a couple of clinical situations myself where we've had very, very complicated, severe late presentations of TBM, and all the standard regimes have been used. And I've on a couple of occasions raised your data sets to say, they've got the relevant rare, albeit rare, complication. There is a very robust observational data, but there just seems to be absolutely no appetite in the UK setting that I've ever experienced where people would take you up on using these kind of TNF alpha therapeutics. And I guess I don't know how you try and make inroads. I guess part of it is experience again, because in a paediatric setting in the UK, you probably see 1 or 2 cases a year. So I think part of it's experience, but it feels like it's a really an important therapeutic option. Related, I've got a question from Professor Ben Michael, and I guess this actually leads on to one of my additional questions. He says, in TBM, especially with edema and hydrocephalus, should we be going for thalidomide before corticosteroids? So I guess I'll let you answer that.
I don't think I don't think there's enough evidence for just purely using it in uncomplicated tuberculous meningitis. And in that case, I would persist with the corticosteroids. If you ask me if I have a TBRS case with a child with threatening visual impairment, or a child who's got a tuberculous abscess close to the brainstem, then yes, absolutely. And then I would proceed with both. I would use thalidomide as well as corticosteroids.
And I guess a slightly probing question I had specifically about steroids is, I'm sure you've seen the huge trial that came out last week in the New England Journal from Guy Thwaites and his team, albeit an adult setting with HIV positivity. But for those that haven't seen this, is a big randomized trial suggesting that there's no additional clinical benefit for outcomes by having randomized corticosteroids, i.e. dexamethasone, for 6 to 8 weeks versus placebo and standard therapeutics. So I wondered if you had any perspective on that recent data, because it wasn't just the outcome of mortality, there was also secondary endpoints where there was no difference between the two. So I'd love to hear what you think about that recent study.
Yeah, Stephen, I'll share your disappointment in corticosteroids. As I've said, we use it for four weeks, as upon diagnosis. What we know is that it helps for the tuberculomas. They disappear more rapidly. But with regard to infarctions, that's what you want to prevent. It doesn't make much of a difference. And as I said, in our setting, we've looked at all our cases over the last 20 years, and 25% of cases, 1 in 4, developed infarctions on antituberculous treatment with corticosteroids. So I think we need something stronger. And we are waiting for the study that's currently being conducted in India to see whether using thalidomide at onset, low dose, whether that confers any benefit.
Okay. And then just a practical, I know you were centrally involved in the treatment regime of a shortened 6-month therapy with increased dosing of isoniazid and rifampicin, and the Cape Town shortened regime. Is that your standard practice now in that setting for your patients? Because I guess, again, limited experience in the UK, even with that data in hand, we still opt, I would say, generally to have a 12-month standard regime.
We were approached by the investigators asking whether we wanted to enroll in this study, looking at the 2 limbs. The problem that we have is if we give our patients a choice between 6 months of treatment and 12 months, they're all going to opt for 6 months of treatment. That was one challenge. We didn't want to change the ethionomide because we thought the benefit of ethionomide is that it has much better CNS penetration than ethambutol, and it also, if you have INH monoresistance, it also covers that option. And then we've been doing studies, myself and Peter Donald, looking at the outcome over a 4-year period, all the cases, and we have a mortality of 3.8%, which is very low. So we were very reluctant to change. And what subsequent studies have shown is, the TB Kids study has shown, is that there is an advantage using higher dosages of rifampicin, and that's what we've been doing, as part of the intensive treatment. And we've also subsequently, after the study, we've changed our dosage regimen. The combination tablets, which used to be 60-60, it's now 75. So the rifampicin component has been increased, and we're hoping that will even improve the outcome even better. But it's my personal opinion that if you really want to make a difference, you need some effective host-directed therapy. Because despite effective anti-tuberculosis treatment with corticosteroids, a quarter of these patients still proceed to have further infarctions.
Okay, that's very helpful. There's a whole series of questions in the chat that I'm just going to continue with, if that's okay. So is it explainable, this is from Sabina Lemesse, is it explainable that patients develop tuberculous abscesses whilst being on anti-TB treatment for a few months? How can we proceed with the management?
As I said, it can happen. It most often happens close to when you initiate treatment. The risk is higher when you've got a high mycobacterial TB load, and if you have HIV, especially if you have a low CD4 count. So these are complications that you will encounter. And if the patient is steroid naive, then you can see whether corticosteroids on its own will help, and that's what I do. If you have a situation which is life-threatening and surgically not accessible, then I would go straight for the thalidomide option. These are rare complications, I must say. I don't want to create the impression that this is a common day occurrence, but now and then you are confronted with these severe complications, and you have to act quickly if you want to have a good outcome.
Great, that's very helpful. I guess I'm gonna, if you don't mind, move on to a question for Tinashe from Henry Messenger, which he specifically asks, is there another brain complication apart from hydrocephalus that can warrant the insertion of shunts? I don't know if Tinashe is on the call and can hear that question. If he can, unmute yourself.
Thanks. Yes, I can hear that question. Am I audible?
Yes, you are.
Yeah. So the short answer is the main indication for shunt insertion is just to relieve hydrocephalus. That's where the majority of experience and the majority of knowledge is. In other brain complications, you may actually remove it. Actually, for example, in the presence of ventriculitis or in the presence of subdural effusion, you actually want to remove external objects rather than inserting it. And yeah, so that's the main purpose.
Great, thank you very much, Tinashe. I actually had some questions for you as well, if that's okay, about shunt infections. I don't know what your experience is like in Ethiopia, but a common question we get asked is from the neurosurgeons: how quickly can I put the new shunt back in? I guess what is, you've taken the infected shunt out, you've given them antimicrobials, but often very quickly the neurosurgeons want to reinsert a new shunt, for very practical reasons, to get on top of the ICP, and manage that optimally. What is your general practice in your setting? I think that's important to understand.
So in my setting, limitation in microbiology diagnostics actually prevent us from going by the book, let me say, just as I presented here. But at least consecutive negative CSF cultures, and always, of course, being guided by the clinical condition of the child, are very important before you decide to reinsert a shunt.
Okay, that's great, and I guess practically we, in our setting at least, we were guided very much by the pathogen, aren't you? So I think the IDSC guidelines, if it's a kind of common positive cocci, it's often, I think the latest guidelines say you can actually reshunt within a week. We can still be on antimicrobial therapy for another few days or a week, but you're actually allowed to reinsert as long as you've got one sterile CSF, which I think is a change in the last few years in pediatrics. So that's helpful. There's a load more questions coming in, which I will just go through if that's okay. So this is a question from Mana Veranda to you, Tinashe. So do you recommend serial spinal taps to increase the chance of getting positive microbiological results?
I'm not sure I understand the question. So serial taps during treatment?
I guess to increase your yield of getting CSF pathogen diagnosis? I guess that's a relevant question to the TB diagnosis as well, which is also very challenging.
Yeah. No, I understand where the question is coming from. So the more CSF you have, then the more likelihood that you may make a microbiologic diagnosis. But then that should be juxtaposed with like it should not delay the initiation of treatment, especially like young children with ventriculitis and shunt infections may often be septic and critically ill. So it should be counterbalanced with how soon you should start treatment. Okay, you have taken one tap, maybe do a second tap, but then that's not going to go on. So yeah, so it's not a straightforward answer, but the more CSF you have, the chances are greater.
Sure. And I was very interested. I'm particularly interested in molecular diagnostics myself, Tennessee. And I saw one of your points is we need to have improved molecular diagnostics for shunt infections. And I'd like to know your opinion about this. I mean, the typical BioFire multiplex that we use in a UK setting, doesn't include the typical pathogens that you would see, the kind of Cutibacteriums and the coagulase negative staph. So it's really hard to know what to do in these children. And actually, what we end up finding is you end up doing 16S, a deep sequencing sample, which comes back way past the event of which treatment's been completed, which is kind of really unsatisfactory. I don't know, do you have capacity for much molecular diagnostics? Oh, and if you do, what sort of molecular diagnostics do you use?
No, that's a different world to us. We haven't used PCR diagnostics from the CSF, but I understand your point that the panels that are set up are mostly set up with community onset infections, and there may be one or two hospital acquired infections, but not really with the typical microbes which cause shunt infections. For example, I'm not sure, I don't know what your experience is. I'm not sure if coagulase negative staph or Propionobacterium acnes are included in those tests.
But they're not. Yeah, they're not under the routine CNS panel. It's more of a kind of typical community acquired bacterial meningitis panel with your, gram negatives, Enterobacteriaceae, and your streps and Neisseria. And there isn't, it's frustrating because you end up, as you were saying, with a culture negative results, and it can leave you feeling a bit uneasy when you're treating, and that can be a great challenge. And you chase your tail by often sending off 16S PCR, but that's never in the time frame of you actually treating. So often empirically treat, which I always find a bit disappointing. Okay, there's a couple more questions for you if that's okay. There's a question from Alistair Joe Campbell. Does improving medical device engineering have a role in preventing shunt infections? Do you have an opinion about that, Tennessee?
I really don't have an opinion in that. I would be interested to hear what the biomedical engineers on call, what their opinion is on this. Totally different experience from mine.
Sure. I guess one point I was thinking about, you were talking about, is that the brain infections group did a really large randomized trial looking at antibiotic impregnated or silver impregnated shunts. And there was really good evidence that antibiotic impregnated shunts reduced infections by about 2/3. But it hasn't been, certainly in pediatrics, hasn't been taken up as a standard of practice. But it feels like that would be a huge opportunity for improving, reducing the risk of shunt infections. Okay, I've got another question from Mark Ellul, if that's okay. For the regarding, he's saying, for communicating hydrocephalus in adults, acetylzolamide, in my experience, is poorly tolerated, causes paresthesia, dose-related effect, and there is evidence that high doses are required for any clinical effect. Have you had much success with this in the setting of TB in kids? So, Ronald, this is a question for you. I don't know if you have much experience of using this acetylzolamide in children with TBM.
And yes, we use Diamox, which is an acetyl. It's an inhibitor of the enzyme. You need to give good dosages because you need to inhibit 99.7% of the enzyme for you to have a clinical effect. So just giving a whiff won't work. We don't see the we don't see the side effects that adults see in pediatric patients. We give it for the first month of therapy. We know we did transcranial Doppler studies, and when you have communicating hydrocephalus, your lumbar opening pressure reflects your intraventricular pressure. And we've shown by doing repeat lumbar punctures, opening pressures on day 3 and day 7, that the pressure in tuberculosis hydrocephalus rapidly normalizes. So the side effects that that's been reported in adults, we don't see that in children.
Yeah, that's very interesting to know. Again, we've got very limited experience. It's good to know that for kind of practice here. I think I've maybe one more question, and then I'll maybe pass this back over to Orla to wrap up. But one question from Ben is Professor Ben Michael. Any advice, Ronald, on TB arachnoiditis causing cord edema infarction with regards to antiplatelets and anticoagulation?
Yeah, I also read the question. I hope you would have missed that one. Very difficult. I've seen this complication in adult patients, and it's devastating because you end up with the cord being ischemic and a quadriplegia or a tetraplegia. Fortunately, it's very uncommon in children. Although, you know, there's spinal cord involvement if you do image the spinal cord in TBM, but we don't see this arachnoiditis that often in children. The handful that I've seen have done poorly. And I think the antiplatelets, anticoagulation is worthwhile trying. But as I said, I've got there's no studies which, you know, to indicate whether we should go that route or not.
Sure. But like you say, there's balance, isn't it? If a quarter of children are infarcting, that's a huge proportion that you could try and ameliorate against what's probably, I imagine, incredibly rare complication.
I think it's worth a trial. I think it's a good suggestion, and you've got nothing to lose.
Yeah. One final question for me, if that's what Ronald is, we've twice had a clinical scenario where we've had children who've responded very well to typical therapeutics with TBM, 12-month regime, and for whatever reason, the neurosurgeons have imaged them, and actually the imaging is profoundly worse, despite them clinically being better. Is that something do you see that lag of, the granulomas and inflammation taking a great deal of time before it kind of, melts away? Is that routine?
Absolutely. We always say that clinical improvement supersedes radiological improvement, and rather be guided by clinical improvement. Some of these mass lesions may even enlarge on treatment, but what you'll see is that the perilesional edema lessens.
Yes.
And that's what causing the dysfunction. So it's and also not to image the children too frequently. Once you start treating the mass lesions, because they take a long time to disappear, to calcify, to become gummatous. If the patient is well, then re-MRI them 3 to 4 month intervals, not monthly intervals.
Yeah, that's really helpful. I think, a couple of times the imaging has been done very early, and then people have chased their tails with very frequent imaging when it feels like the child in front of you is markedly better. You feel like you should be guided by that. So that's really helpful. Okay, one very last question. Can a large volume CSF increase the sensitivity of microbiological diagnosis in TBM? Would you recommend 5 mils or even up to 10 to 15 mils?
I think at least, if you look at Guy Twait's and his study, he said at least 6 mils or more. You do increase your culture yield. Obviously, for gene expert, you need very little, so it's not relevant for gene expert testing. But for culture, larger volumes increases culture positivity. And if it's communicating hydrocephalus, I think then it's actually beneficial to take off good amounts of CSF. You obviously have to be cautious when you have a child with non-communicating hydrocephalus, because large volumes would put that child at risk.
Okay, that's really great. We're going to have to leave it there. There's a lot more questions, but unfortunately we're kind of out of time. So I'd really like to say a huge thank you to Tinashe and Ronald for 2 very practically relevant, useful talks that I've certainly learned a great deal myself. I hope everyone else has. It's been very, very, very interesting. So just moving on, I'll let Orla take over now to talk about some potential scholarship opportunities.
Great, thank you so much. I'm just going to reshare, bear with me 1 second. So thank you so much, Stephen and Professor Van Toorn and Associate Professor Alemayehu. That was a really interesting and I think really highlights the importance of sharing our research between different countries and different medical settings, and also considering the kind of ethics when applying some of this research within pediatric cohorts. So I hope everybody learned something. I certainly have. I will do a whistle-stop tour through some of the opportunities we have, just for time purposes, and there are QR codes which you can scan, and the recording will be put online if anybody wants to re-access this information. So firstly, just to highlight that there are scholarships available for nationals from low and middle income countries, which will cover the cost and some travel and accommodation expenses for the Liverpool Neurological Infectious Diseases course, which happens on the 19th and 20th of June next year. So for anybody that might be interested about learning more on neurological infectious diseases, please do register. Next, there is a teaching and research fellowship in medicine, which will open from the 1st of January next year for 3 years at the Northumbria Healthcare NHS Foundation Trust. And the applicant does not currently need to be in the UK for this opportunity, but does need to have 1 year of experience working in the NHS. Again, this is an exciting opportunity coming up. Then to highlight that there's currently a call out for applications for the Liverpool Clinical PhD programme for health priorities in the Global South. And that's not just for doctors, for lots of different healthcare professionals, including veterinarians, midwives, nurses, and allied professionals. And unfortunately, this is for UK registered healthcare professionals only, but there is the opportunity with it to spend 2 or more years in a low or middle income country to carry out research. Then I'd like to highlight that on the 2nd of November, so very soon, there is a COVID CNS webinar, which again is free to join. And for anybody interested in the work being done to investigate the neurological complications of COVID infection, please do join. Again, there's a link on the page. And last but not least, just to highlight that on the 17th of November, we have our final session of the year for this year, the Global Health Network Clinical Exchange on Neurosurgical Health for All. And it should be a really exciting session. It's being chaired by Professor Key Park and Associate Professor Abanesa Tursit and Dr. Tariq Khan are speaking. So please do register for that, and hopefully it will be a very good session. And with that, only 2 minutes over time, I'd like to thank everyone for joining, particularly to thank our chair, Stephen Ray, and to thank Professor Van Toorn and Associate Professor Alemayehu for joining and for providing a really interesting session on pediatric brain infections. And hopefully we can all maintain correspondence to try and develop and standardize care for children with brain infections. So thank you very much, everybody.
Thanks very much, Orla. Okay, thank you, everyone. Have a nice afternoon. I hope everyone's enjoyed it as much as I have. Take care.